Good morning. Today we will have a case presentation. It's more of a short case, but in DNB there is nothing called short case. We are going gradually physical, so this will be like a case discussion only. So today we will have a discussion on lumbar hernia, represented by Dr. RM Jyoti, who is a third-year junior resident at MR Bangalore Hospital, and Dr. Sarfraz J. Beg, who is in charge of digestive surgery clinic at Bellevue Clinic, will take us through this scenario of lumbar hernia. Dr. Beg has special interest on hernia surgery, so we'll have a good discussion on lumbar hernia. So, do you like an exam scenario? Jyoti, you can share your screen.
Good morning, sir. Mr. X, 38 years.
Good morning.
Good morning, sir. Mr. X, 38 years, resident of Jadavpur, traveled by occupation, came to the hospital with chief complaint of swelling in left loin for 2 years. History of present illness. Patient was apparently normal 2 years back, and present illness started as swelling in upper part of left loin, which is injurious in onset, gradually progressive, and attains the present size of 5 to 3 centimeters, and swelling appears on standing, walking, and disappears spontaneously on lying down position. And swelling is associated with intermittent mild dilating pain. No history of any other swellings in the body. No history of trauma, fever. No history of bowel and bladder symptoms. No history of chronic cough, breathlessness. Past history. No history of similar complaints in the past. No history of hypertension, diabetes mellitus, bronchial asthma, tuberculosis. No history of any prior surgeries. Personal history: takes mixed diet, bowel and bladder habits are normal, no habitual addictions, married, 2 children, healthy. Family history not significant, treatment history not significant, allergic history not significant. Summary of the history: 38-year-old gentleman presented with swelling in upper part of left loin for 2 years, which is gradually progressing and attains the present size of 5 into 3 centimeters, which appears on standing and walking and disappears on lying down position, and associated with intermittent dull-aching pain without bowel and bladder symptoms.
She will continue, or would you like to have some discussion on history presentation?
This is a brief thing. Tell me, what is, from your history, the possible etiology of the hernia?
Sir, as a patient is of 38-year gentleman, and it is patient is not having any history of trauma and no history of any history of fever, and patient is so I'm thinking it is of primary only weakness of the abdominal wall.
Okay, so first give me a provisional diagnosis, then we'll take this question again. This is the summary of the history, so let's proceed a little further, then we'll take the question again.
Okay. Coming to general examination, patient is conscious, coherent, cooperative, well-oriented, time, place, person. Karnowski performance status 90, height 160 centimeters, weight 65 kg, BMI 24.5. No pallor, no icterus, no cyanosis, no clubbing, no engorged veins, no generalized lymphadenopathy, no edema. Vital signs: pulse rate 84 per minute regular in right radial artery, blood pressure 130/70 mm of Hg in right upper limb in supine position, respiratory rate 14 per minute regular, temperature 98.6 Fahrenheit. Coming to the local examination, after taking proper consent with adequate exposure, patient is examined in lying down position and standing position. On inspection, abdomen is normal, umbilicus is normal position. A globular swelling of size approximately 5 into 10 centimeters situated in left lumbar region, just below the left costal margin. A surface appears to be smooth with well-defined margins. Spin over the ceiling is normal. Cough impulse is present. Swelling is reducible on lying down position. No other visible swellings are seen, and other hernial orifices are normal. External genitalia are normal. Palpation: no local rise of temperature, non-tender. All experimental findings are confirmed. A globular swelling of size of 5 into 3 centimeters situated in left lumbar region, just below the 12th, with smooth surface, well-defined margins, soft in consistency, and expansile cough impulse felt over the swelling, with abdominal wall defect of size 3 to 2 centimeters is palpable after swelling is reduced. No organomegaly, and other hernial orifices are normal. External genitalia are normal. But on percussion, dull note over the swelling. Auscultation: normal bowel sounds. And distal rectal examination: normal tone, no growth pattern. Systemic examination: respiratory system, normal breath sounds, no added sound. Cardiovascular system, normal heart sounds heard. So central nervous system, no focal neurological deficit. Spine normal, no non-tender, no deformity. Summary of the case: 38-year gentleman presented with swelling in left part of left loin for 2 years, which is gradually progressing and attains a present size of 5 to 3 centimeters, which appears in standing, walking, and disappears in lying down position, and associated with intermittent dulling pain or the swelling without bowel and bladder symptoms. On examination, gender survey is normal. Globular swelling of size 5 to 3 centimeters is situated just below the 12-3 in left lumbar region with well-defined margins, reducible and lying down position with expansile coughing pulse over the swelling. Abdominal wall gap of 3 to 2 centimeters swelled. Systemic examination is normal. So my provisional diagnosis: case of 38-year gentleman with left lumbar hernia through this superior lumbar triangle without any complications.
Yeah, so this is, you've come up to this. So tell me, what are your points in favor of the fact that this is a hernia?
Sir, a swelling which is appearing on with straining factors, and it is reducing on lying down positions.
That is one.
That is from your history.
And reduce and lying down position, and on examination, if expansile coughing pulse present, and it is reduced lying down.
So cough impulse and reducibility. In your examination and after your history, you've come to a diagnosis of superior lumbar triangle hernia, right? This is what your diagnosis is. So now, can you tell me the etiology of your hernia?
Sir, on history-wise, patient is not having any history of any trauma or any prior surgeries, and so I'm thinking it is of primary hernias.
So lumbar hernia may be either a primary or secondary. What are the secondary causes of lumbar hernia?
Sir, if any case of any prior surgeries is there and leading to the defect in the fascia leading to the hernia.
What type of surgery is being done in this region?
So renal surgeries.
Yes.
And
renal surgery.
And dorsal spine surgeries can.
Yes. Okay. Anything else?
Good.
Abscess drain.
Apart.
Yeah.
Yeah. Apart from surgery now.
Sir, abscess surgery.
Another
trauma,
important.
Any history of trauma,
yes,
blunt
very
trauma.
important. Trauma. Trauma can cause disruption of the abdominal musculature. Yeah. So there is no such history. So you should think this is a primary hernia.
So you said superior lumbar triangle. Can you tell us the boundary of this triangle?
Yes, sir. It is medially it is formed by the serratus anterior inferior muscle, and laterally by the internal external oblique muscle, and superiorly by the 12-3.
Serratus
You said external or
medial.
internal?
Medially is what?
Lattice muscle.
No, medial is sacrospinalis, erector spiny muscle.
Erector
Above
spine.
is the 12-3. And medially or anteriorly is?
Internal oblique.
Yeah.
Internal oblique. So if there is a superior lumbar triangle, you think there is also an inferior lumbar triangle?
Yes, sir.
What is the boundary of the inferior lumbar triangle?
It is inferiorly bounded by the iliac crest, and medially by the latissimus dorsi, and laterally by the external oblique muscle.
Wonderful. Great. So now that you have told us about these triangles, can you tell us what is the common presentation in terms of age and gender for a superior lumbar triangle hernia?
So usually male patients are common.
Superior. Okay, just give a general description. What are the patient stature, patient stature, which is produced into this hernia? This lumbar triangle may be either narrow or maybe wide. So when do you think the hernia should be more?
So when a patient having the wide.
Yes, when the triangle is wide. So the question was, what are the important situations where you can find this hernia? Like
wide built.
Tall, thin, or wide, broad pelvis associated with this hernia?
So broad.
Broad. So who has broad pelvis?
Females.
Female sex. There's more incidence is in female. Then, if you talk of say the muscle weakness, so which age group?
Old age group are more common.
Yes. If you think of trauma as a secondary cause, in that case you may have this earlier age group, but otherwise say elderly patients, and more likely it's common in females.
So how will you confirm your diagnosis?
The confirmation, it's clinical, and I want to confirm it is by CT scan. If clinical hernia is clinical diagnosis, and to know the exact defect size and content, I want to go with the CT scan of the.
Yeah. So what will the CT scan tell us? What are the points that you will see in the CT scan?
We can know the defect size and the content and the musculature of the abdominal wall also.
What do you want to see in the musculature of the abdominal wall?
Sir, any weakness?
You cannot see weakness in
thinning of the any abdominal
yes.
wall.
Thinning, yes. So let us say on the CT scan you find that the entire left loin muscles are thinned out. It's thinned out, and not having a circular defect as you see in a hernia convention in a CT scan. What would your advice be, and how would your management differ?
Sir,
the scenario that is given by Dr. Beg is also defined as a particular type of hernia. That means there is a diffuse bulge. If you have this sort of thinning of the muscle, as the patient stands, patient strains, there will be a diffuse bulge in this area. So if you go to the classification of these lumbar hernias, there are different types of hernias. One is this, which is known as a diffuse lumbar hernia. Okay, so there is a diffuse bulge. So what to do?
Sir, as there is a loss of domain.
No, loss of domain may not come, but this is just weakness, and you find that there is a diffuse hernia involving the whole of this loin. It's not only the triangle. You see, this hernia can occur to the superior triangle, inferior triangle. Apart from this, once you say secondary to the renal surgery, you go through this triangle and you divide the abdominal wall muscles. So it can be a diffuse hernia occurring through this scar. More of a no, pseudo hernia is different. Pseudo hernia is different. What is pseudo hernia? As you said,
any abdominal nerve paralysis leading to the
nerve paralysis leading to the bulge. That is one. Second is, if you talk of this lumbar hernia, what you may have. One type of lumbar hernia is just a bulge of the extraperitoneal fat. There is no hernial sac. There is no hernial sac. Second type of lumbar hernia is there is a bulge and it contains a peritoneal sac. Not exactly peritoneal sac, it contains a sac with the viscera attached to this, more like a sliding component. This is described as a paraperitoneal hernia. And another is you have a classical peritoneal sac and it contains some contents, small gut or whatever. So if you have a diffuse bulge and weakness associated, what should be your approach?
Such.
What do you think?
I'm not sure.
Okay.
So whenever you see these bulges or a pseudo hernia, which can be of various, etiology, as Makunda said, denervation, sliding, or no sac but fat out there. So in at least denervation hernias, it's a diffuse bulge. There is very minimal role of surgery. It is unlikely to be of any benefit. This is very important because if you make a diagnosis of lumbar hernia, you did a CT scan and you found this is only a thinning of the entire left abdominal wall, and it's a global defect, a diffuse defect, rather than a isolated defect. Then in that situation, there is hardly any benefit from surgery. So doing a surgery would be unnecessary and you would be spoiling and probably injuring more of the abdominal wall muscle. Okay, so that is a very important thing to understand in lumbar hernia. Probably the most favorite question from people who will, ask you about lumbar hernias. So let's say you did see a defect on the CT scan, right?
Yes.
Then how would you manage? You saw a circular defect of about 5 centimeters in the left loin. It's a superior lumbar triangle hernia. What is that name of the gentleman after whom this hernia is named?
It's a Grisfeld lesson.
Greenfield.
Greenfeld. Gryn. So this surgery, this hernia, how will you manage this patient now?
Sir, as it, after investigating and confirming the diagnosis and proper fitness, I mean with basic investigations and anesthesia, I will proceed with the surgeries.
What surgery? You have to now specify. Now you have option for open and lap. What your preference? What is the standard description? You can tell us.
Sir, open up.
Then you say what in the exam you cannot say open or this. If you say open, you have to justify why you use open acceptable. What are the techniques in open? So in superior lumbar hernia, you have a gap between the erector spinae and the internal oblique. And if you see the floor is what? Lumbodorsal fascia. So how are you going to achieve this hernia surgery? If it is open approach. Open approach is what? Anterior approach.
Yes. Okay. So any idea if you do open approach, you will of course use a mesh, right?
Yes.
Okay. And then if you use a mesh, which plane and how will you fix? These are the two questions all examiners are going to ask you. What approach? What? Where are you going to put the mesh and how are you going to fix it?
So prepared on a mesh.
Okay. So you want to do open approach and extraperitoneal plane. You want to mesh placement. And how would you like to fix it, or whether you would like to fix it?
Sir, usually won't fix because abdominal wall musculature will keep the in plane.
Yes, good. So we need minimal fixation with extraperitoneal repair because the intra-abdominal pressure itself is going to leave it fixed. What kind of mesh would you like to use?
Polypropylene mesh.
Okay. And would you like to use a macroporous or microporous mesh? This is not required at you. Okay, microporous. Fine. I think that is one approach. What are the alternative approaches?
So laparoscopic approach.
Yeah. So we now like to call it endolaparoscopic approach because you can either go through the peritoneum or you can in fact avoid the peritoneal cavity and get into the extraperitoneal space endoscopically and repair it. Fine. Makunda?
Yes.
What else?
The point is, there are some indications where you feel that a laparoscopy approach is not feasible. Where? In a lumbar hernia.
If defect is more.
Yes, if there is a diffuse bulge and wide bulge, it is difficult to manage it laparoscopically. In that case, there is a technique in open called it's a double mesh technique, where you dissect the hernial space and place one mesh in the extraperitoneal space, and then close the fascia and put another onlay mesh. So it's a double mesh technique. Okay, so little about it can be a hernia to inferior triangle also. So suppose you have a hernia to inferior triangle, and inferior triangle, you see the difficulty in repair is you have a bone as a boundary, iliac crest. So is there any role for doing non-mesh repair for inferior triangle hernia?
So if defect size is very small, we can go, but if usually it is a bone defect.
There is some description that you can use some rotational flaps based on gluteus maximus or medius. You can rotate this gluteus flap and cover the defect. Otherwise, again, the approach is same. Either go by anterior approach using a mesh, or you go by laparoendoscopic approach. Okay. You said without any complications. What can be the complications of lumbar hernia?
So it can be if content is of any bowel structures, maybe obstruction will be present.
So again, same is irreducibility is first complication. And usually the contents are not very large in small inferior triangle. So if it is a gut content, it can be either a Richter's hernia or it can be a hernia causing complications of intestinal obstruction. And if you have a diffuse hernia in this site, even kidney can be a content of the hernial site. And this kidney, because of being contained in the hernial sac, may have obstruction also.
So my advice is when you talk about complications for any viva, say there can be general complications, there can be local complications. General could be organ related, cardiac, pulmonary, renal, hepatic, uh, and of course something like DVTs. These are your general complications. Local complications, especially for hernia, are what would you say? Tell me local complications for hernia.
So it reduces local, if it is chronic long-standing, it may be leading to skin changes and irreducibility, obstruction, and strangulation.
No, I'm talking about post-operative complications now. I wasn't talking about the complications of the hernia. I was talking about post-operative. That's why the general complications
Surgical site
and
infection.
local.
Surgical site
Okay.
infection.
Yeah.
And
So again, I like to divide. So if you say general complications, organ-related, and something like systemic, like DVT and pulmonary embolism, and at the same time, when you say local, it could be intraoperative, it could be post-operative. Intraoperatives are injuries, right? In hernia surgery, injury is a big issue. And B, when we talk about post-operative, you can talk about a recurrence, SSO, SSI. So, and pain. So recurrence, SSO, SSI, and chronic pain. These are the 4 outcome measures that any hernia surgeon would like to, or any surgeon would like to hear as far as hernia is concerned. So recurrence, surgical site occurrences, surgical site infections, and chronic pain. All right. So tell me, in this lumbar hernia surgery, what do you think is about the recurrence? Do you think it's low compared to midline, high compared to midline? What do you think?
low compared to
It's not low.
sorry, if,
It's a difficult hernia to repair.
Yeah. Yeah, it's an atypically sited hernia. They are also called boundary hernias or atypically sited hernias. So atypically sited hernias, when they're close to any bones like rib cage, spine, suprapubic, antesupplex spine, these hernias are going to be more difficult to treat, more difficult to, space creation is difficult, mesh fixation is difficult. Therefore, there's a high chance of recurrence. That is why the recurrence is high. So lumbar hernia complication, local complication, increased recurrence. That's A. And that's the answer. And what about surgical site? What about chronic pain? Do you think that will be lower or higher compared to midline hernia?
Compared to say, but it is near to bone, and so pain will be.
So the nerves are there in the lateral. They are all arising from the spine as thoracolumbar nerves, right? Intercostal nerves and then lumbar nerves. So if you're putting in the mesh in that same region where the nerves are arising, there's a high chance of chronic pain. Therefore, again, chronic pain and recurrence are higher in lumbar hernias. Okay.
Yes. What nerve and vessel come in relation to the superior lumbar triangle?
Said if it comes to medially,
there is an important neurovascular bundle in relation to the superior lumbar triangle, which is not there in inferior lumbar triangle. It's subcostal. Subcostal vessels and nerves passes through this triangle. So it is said one of the factors for hernia formation is because of injury to this subcostal nerve if you are doing a renal surgery. That can cause atrophy of this muscle. But inferior lumbar triangle, there is no nerve coming out vessel, just a fascial gap. Yeah, I think it's a
good
short case.
Yes, very well done. Very well done. Yeah. Anything else, Maganda?
Chalo. Any hernia tips you like to give?
I think we've given them enough for a lumbar hernia. Even senior surgeons get
actually the anatomy is important. You have to know the anatomy of the both lumbar triangle and then the etiology. If you say the etiology, what is the etiology of lumbar hernia?
So it can be.
It can be congenital. There may be congenital lumbar hernias. It can be acquired. In the acquired, it can be primary or secondary. In secondary, you have discussed that it can be either because of a surgical incision, it can be a major trauma. It's a minor trauma that causes lumbar hernia. It's a major trauma causing disruption of the abdominal wall muscles, or can be infection. If infection in the retropedial space, psoas abscess, this can
Right.
point to this triangle and cause herniation. And if you talk of other etiological factors, apart from these major three components, you may have a case of increased intra-abdominal pressure. Patient having chronic staining factors, which can cause herniation to this triangle, because these are all defined weak areas.
Yes.
And then in presentation, what may be the presentation of this patient having lumbar hernia?
So swelling.
One is asymptomatic. This patient, if it is just a fatty hernia or just a paraperitoneal hernia, patient may have no symptoms. You just detect this hernia on examination. Third is they present with a bulge, may present with pain, and if it is a large hernia, patient may have other features of bowel obstruction, urinary obstruction, may present with also strangulation. So they are the usual presentation. And then, as you said, regarding the investigation, it's a clinical diagnosis. The point comes when the hernia is irreducible. What came the differential diagnosis of a swelling in the superior lumbar triangle area? If it is not reducible, reducible is yes, is a hernia. Apart from this now, yes, lipoma.
Mm.
Or subcutaneous swelling. Yes, lipoma, fibromas, neurofibromas. It can be a chronic abscess. Okay, so there are a lot of other swellings which can come in this area. But if he says it's definitely a swelling which is reducing on lying down, on can manipulate, reduce it, then the disease should not be brought into a diagnosis of lipoma. You think of a swelling which is not reducible. And then investigation is you need to do a CT scan to assess the gap properly and the status of the abdominal wall muscles.
Yeah.
Okay, then we can.
Okay.
Thank you. So for next
Thank
month,
you.
next month I kept on class for you also.
ठीक है. Sure. Thank you very much and very well done. Very well done. Thank you. Thank you.